Well, welcome to the monthly Lunch and Learn that is co-sponsored by the Positive Sobriety Institute of RiverMend Health and Northwestern Medical Center's Division of Addiction Psychiatry. We have a very special presentation today and very much appreciate your attendance. I'm Dr. Dan Angris, the Medical Director of the Positive Sobriety Institute and Associate Professor of Psychiatry here at Northwestern. Dr. Dupont is our speaker and esteemed speaker. He requested that I not give a long introduction, but I'm going to defy him because it's remarkable what this man has done and has done for our field and has in so many ways benefited myself and so many others with this disease. So I'm going to read this through. For more than 40 years, Robert Dupont has been a leader in drug abuse prevention and treatment, a graduate of Emory, received an MD from Harvard Medical School, completed his psychiatric training there at Harvard and the NIH in Maryland. He has an active practice of psychiatry specializing in addiction and anxiety disorders. He's been clinical professor of psychiatry at Georgetown School of Medicine since 1980. His many contributions in the field include being the first director of the National Institute of Drug Abuse and the second White House drug chief. Amazing accomplishments, either one of those alone, right? Much less both. He was Director of Community Services for the District of Columbia Department of Corrections. He has, heading up parole and halfway house services. Served as the Administrator of District of Columbia Narcotics Treatment Administration, the NTA. He became the President of the Institute for Behavior and Health. He's published extensively, over 300 professional articles and 15 books and monographs. His books include, and there's such a nice variation, Getting Tough on Gateway Drugs, A Guide for the Family, A Bridge to Recovery, An Introduction to 12-Step Programs, and The Selfish Brain, Learning from Addiction. In 2005, Hazelden, the nation's leading publisher of books on addiction and recovery, published 3 of his books on drug testing. He is now Vice President of Benziger, Dupont & Associates, a leading national consultant firm dealing with substance abuse, founded in 1982 by Dr. Dupont and Peter Benziger, who himself was the former of the Director of the Drug Enforcement Administration. Dr. Dupont is an active member of the RiverMend Scientific Advisory Board, which is where we were able to meet each other. And I can tell you that he has been a leader in researching and understanding the physician health program contributions to excellent outcomes, and how we can hopefully translate these excellent outcomes that we see with properly treated and monitored physicians to other populations. So without further ado, I respectfully want to introduce Dr. Robert Dupont. Thank you.
Thank you very much, Dr. Angris. Well, I am thrilled to be here with you today. How many people here work at PSI? Not everybody. I thought the group would mostly be that. Well, that's interesting to me. I want you to know what I think about Dan Angris and what he's doing here. This is the state of the art for treatment of addiction. What you see every day and what you're doing is as good as it gets anywhere in the world. And I am here to honor Dr. Angris and also a man who I revered for many years from here in Chicago, Marty Dupont, who is also very much of a leader in this field and somebody very, very special. Well, I've got some slides here that I'm going to start with, but I'm going to bail out of the slides partway through so we can just talk to each other more openly. But I want to tell you how I got to this, what happened. As Dan said, I started in the addiction field. Let me say just a word about how that happened. I finished my training after going to Emory, Harvard Medical School, Harvard for my residency, and NIH. That's a pretty classy background. But the question was then I was to find a job. What was I going to do? And I had worked one day a week in a state prison in Massachusetts called the Norfolk Prison. And I fell in love with the prisoners and their stories. So I went to work for the District of Columbia Department of Corrections, which was a very unusual career choice. And in that setting, the city of Washington, this nation's capital, was experiencing a crime epidemic that was nationally focused on. It was called the crime capital of the nation. And so the question was, what was driving that? And as a new person coming into the Department of Corrections that year in 1968, I did drug testing of all the people coming into the prison and discovered that 44% of them had heroin in their urine, and showed that the crime epidemic was driven by the heroin epidemic. And that was published in the New England Journal of Medicine, which again, a kind of a classy place to publish things. And it changed the way the country thought about both. And it changed my life because it got me hooked on heroin and heroin treatment and drug treatment, and everything else flowed from that in that. But over this course of this nearly 50 years, it's going to surprise you to learn that I got older over that time. I guess it surprised me probably more than it surprises you. But there came a time when I thought, about a decade ago, well, how good could outcomes be? Because I was very aware of the failures of addiction treatment, having devoted my life to this. And I had many physicians, patients of mine, and I watched what happened to them in my practice. And so I said, okay, let's think about what happens to them and what we can learn from that. And so I recruited the world's greatest evaluator of drug treatment, a professional named Thomas McClellan, president of the TRI, the Treatment Research Institute, to be my co-author. And we did the first national study of the state physician health programs ever done. Let me show you some of the data from that. We got 16 programs that participated in this, 904 patients, and we looked at what was happening to them. So I'm going to tell you a little bit about that, but that's how I got to the PHPs. It was because I was interested in what the limits were of this, how good could it be, and it was very interesting. Okay, so here are the three things I want to talk about for our objectives. First of all, it's very odd that addiction is a lifetime disease. It is not something like the cold you get and it's gone. And the treatments are all short-term. Even the longest-term treatment is short-term. That doesn't fit. That doesn't add up. And it's full of important meaning to us. Okay, the second thing is, what is it that goes on in the PHP care system that's different? What characterizes the system? How do you describe it? And you can't see the bottom here, but where I'm really going with this is that the standard physician's healthcare program is 5 years. And so I go back to Tom McClellan, my co-author on a paper that's published about a year ago, that said all drug treatment, not just for physicians, all drug treatment should be evaluated on the treatment's ability to produce stable 5-year recovery, analogous to cancer. How good is this treatment, whether it uses medication or not, whether it's residential or outpatient, any treatment? at producing 5-year recovery. And that is sort of the result of my 10 years is to encourage the field to adopt that standard. Okay. The standard now, when you say evidence-based treatment, many of you have seen that term, evidence-based treatment, is the standard that the FDA uses, which is that the people who are taking the medicine or receiving the treatment are using 20% less opiates or other drugs than the people on placebo. And if they are, that's called evidence. That's not what I'm working on. I'm not talking about a 20% reduction in drug use. I'm talking about recovery, and that's a huge difference. Okay, what are the obstacles? I don't read all this, but the people who have substance use disorders don't want treatment. And when you refer them to treatment, they don't go. And when they go, they drop out. And when they complete, they relapse. And here is a number that no one else will ever use because I've just come up with it, but to me it's very compelling. The drug treatment field is starved for resources, whether it's government programs or health payment programs. It turns out that illegal drug users in the United States spend $100 billion a year for drugs. The entire drug treatment field, including alcohol, all public and all private, costs $34 billion a year. Drug users can pay for all the drug treatment in the country 3 times over every year with the money they're paying cash. They don't have credit in the drug sales when they're buying them. That tells you something very, very important about this entire field. Okay. Now, today's treatment, I mentioned it's a lifelong problem with episodes of care and often for one treatment. And many patients, especially in medication-assisted treatment, continue to use drugs and alcohol while they're in treatment. That would surprise you here, but that is the reality for most of the treatment. And here are the 3 missing elements. First of all, the definition of long-term recovery is the goal of treatment. You just don't hear that in most treatment programs. They don't get to that as a way of thinking about what they're doing. In fact, the goal most of them have is completing treatment. And completing treatment will be a number like 25 or 30%. It's not 90% in that. And then here's the other thing that's missing from most treatment: provision of sustained post-treatment monitoring and professional and peer support. So it isn't just what happens in the treatment, it's what happens after the treatment. Insistence that others around the patients of them of a sustained abstinence and having consequences for use. All of those things are what the PHPs do, and none of those things are what's happening in most drug treatment in the United States right now. It's a very big change that I'm talking about. Now, one of the things, medicine is always changing, but it's changing more now than in the past in very dramatic ways. And there is a movement in medicine that is extremely positive for the treatment of addiction. And that is to focus on serious chronic conditions that are highly prevalent and expensive, that produce social costs, and have the healthcare system responsible for preventing those, for identifying them, for intervening, for treatment and monitoring of those for the lifetime of the person. That is the new standard for healthcare. And you think about applying that to substance use, and you see an entirely different landscape before you once you get to that frame of what it is. And it is very interesting to me that the key to me is this long-term accountability of the healthcare system for these outcomes. Once you say that's our job as doctors, as healthcare, to identify those problems, to intervene, to treat, to monitor. That's our job. That changes everything. That's a whole different deal that we're talking about. Well, what happens in the physician's health programs? The treatment, as you know, is a few months, or maybe as little as 1 month. Some physicians are treated just with IOP, but mostly it's residential, and mostly it's 1 to 3 months, sometimes longer, not less than 1 usually. But it's extended accountability for abstinence for 5 years. That's a huge deal. And the fact that the physicians get all the support, and of course the immersion in Alcoholics Anonymous and Narcotics Anonymous, the 12-step fellowships, is absolutely central to what is going on. Here are some things. I think we've talked about those. I'm not going to worry about those. Here's our results. The 904 physicians. 64% completed. This is a single contract. This is not their lifetime experience, just 1 episode of care. You think about this. This is what happened in 1 episode of care. 64% completed the contract, 16% extended the contract, and just shy of 20% failed their contract over that 5-year period of time. Again, you think about how many interventions related to substance abuse we have anything looks even remotely like that over 5 years. Then the physicians were mostly licensed and working. Some of them had their licenses revoked. You can see the bottom one, it's 11% had their licenses revoked. Okay, this is my favorite slide about this. And the physicians have to have, every day they're subject to monitoring on a random basis. If they don't show up, it's considered a positive test. 78% of these physicians in 5 years had no positive test for alcohol or drugs. And of the people who had any positive test, 2/3 or 14% of the total had only 1 positive test. So only 8% had more than 1 positive test in the 5 years of monitoring, which is really quite remarkable. There's virtually no use of pharmacotherapy. 1 patient was taking methadone, but that was for the treatment of pain and not for the treatment of addiction. And 5.1% used naltrexone, and much of that was to treat alcohol as opposed to opiates also. Okay. This is a question that comes up about the opiate patients. The physicians, basically, half of them were alcohol, 1/3 were opiates, and 1/6 was everything else. And if you look here, you'll see any positive test. The alcohol only had 20%, any opiates 23%, non-opiates 25%. I think this one is also very good. Here's the completers. Of alcohol, it was 58%. Opioids, 64 or 65, and 64 for the non-opiates. In terms of, there's no statistical difference in the outcomes of the opiate from the alcohol. And that's something that I think most of us see in treatment. It doesn't really matter what the drug is the person is taking. The problem is the same. And that's why the same treatment is used for in most cases. Now, we went further than that. Is to say, many people say, well, Bob, that's good because they're monitoring and they're going to lose their license, and I can imagine that they do that. But what happens when they're no longer monitored? What happens after that? So we did a preliminary study of 155 physicians who were 5 years or longer after their last mandatory monitoring. Okay, this is the stability. Now, they were not all the physicians, they were the physicians who successfully completed. So the question was, of the people who complete successfully, what happens to them then? That's the question. Okay, 89% completed their contract without any relapse, which fits with what you saw about the use that 78% of them had no positive tests. 96% 5 years later were in recovery. Now, we didn't do a drug test of them, but the things that they said on this questionnaire were very, Very convincing. Anyway, 96% consider themselves in recovery. And we asked them, what of the things in your 5 years in the PHP, not in your treatment, which is a month or 2 or 3, in your 5 years, what was the most important thing? And we made them pick just one thing. And we had a long list of possibilities. It's pretty striking to me that the most positive, the highest level was 35% was going to meetings, as the 12-step fellowships. And that's not too surprising to many of you. You see the heads nodding. But I think this is quite stunning. 26% said their treatment experience was the most positive experience, and the treatment was only a month or so out of the 5 years. But that treatment experience really mattered to these folks. And I think it sounds right to me, and it's also very important. Now, what I've done with this is say, okay, how does that apply in other situations? And Dan was talking about that, and I think that's a very good question. How limited is this to physicians? And the pilot's experience is very similar, and they have similar stunning results from that. I'm not going to go into details of that, but that's an assertion I want to make. The attorneys, not quite so much, but there's some similarities. They have a little harder time with the strictness of the standard, but it's basically a similar kind of experience. There is here a question I'm asking: how can we justify having a treatment approach that is so good for physicians and not have it available to everybody? And I think that's something worth thinking about and looking at some of the criticisms that are made of this. One, that they're unique. And I want to just point out, and I'll show you some data here, that a similar approach is used in the criminal justice system in a program called Hope Probation. And that is the most different demography that you could get from physicians. This is convicted felons, average of 7 prior arrests, high school dropouts, many unemployed, and in this case in Hawaii, their smoked methamphetamine is the major drug that they have in Hawaii. And you'll see here some results. And here's the elements of this. Intensive random testing. It wasn't all probationers, it was just the high-risk probationers that were in Hope Probation. The ones who had failed or had a very bad background that predicted they were going to fail. And it has 0 tolerance for any violation, including any drug use. So they had the same kind of thing. Every day they had to ask the question, do I have to go today? If they had to go on a random basis. If they didn't show up, it was called a positive test, just like the physicians. And it went on for years. This is a result of 1 year of that testing. And a missed appointment was considered or a missed probation appointment. It wasn't just drugs, would be considered a violation. Now, what happened if they failed? What happened if they failed is they'd go to jail right then for 2 or 3 days. That's it. They don't go for 10 years. They just go for 2 or 3 days, but it's that day. And what the judge who invented this approach said, these folks are used to rolling the dice against 10 years of prison as long as it's later and uncertain. So you don't know whether it's going to happen. And the criminal justice system is, in its lack of wisdom, focused on long consequences that are uncertain and delayed. A terrible way to change people's behavior. And what this program, Hope Probation, does is right now, and that's just what happens with the PHP, a single positive test and the doctor's out of the practice. Right now. Boom. And that changes the behavior of the prisoners, of the convicts, as well as the physicians, that approach to it. Now, this is different. They don't all have treatment. they are told they're going to have to meet this standard, and if they need to use treatment to meet the standard, they're provided treatment. They really, Judge Ahm, who started this, is a big believer in treatment. But what's interesting is most of the people can meet the standard without going to treatment, even with the heavy addiction, which is surprising. And also, unlike the physician's health programs, they're not required to go to 12 steps, but it's encouraged, and many do, but not all. So here are the goals of the HOPE program, short-term and long-term. And here's the results. This was a randomized controlled trial. So you had people in probation as usual and HOPE probation. 55% less likely to be arrested for a new crime, 72% less likely to have a positive drug test, 61% less likely to miss appointments, and 53% less likely to have probation revoked. And they had 48% fewer days of incarceration. You say, well, they're going to jail right away. They have less incarceration than the other people do when this is done. Now, this approach from HOPE probation is applicable to 5 million Americans who are on probation and parole, 80% of whom have substance use problems. That's very exciting application of this model. Here's the distribution of the positive tests over the 1-year period of time. You see 51% had none, which is pretty striking. 28% had 1, 12% had 2, and 1 out here had 6 over the course of that year of study. Again, a pretty impressive clinical population that lack leverage of this. And this is something that I think is really important to think about. There are many other ways to produce leverage besides the criminal justice system and the physician's health. And that includes health care, that includes employment settings elsewhere in the criminal justice system also. But the key to me is the family. The key to me is what the family is going to do. And I was talking to Dan Engris about this. The family with somebody who's got a substance use problem has a terrible dilemma. And that is, if they're tough and say, you're going to participate in this family, it's going to be a condition to you to be drug-free and go to meetings, which is what the PHP is all about, has got to deal with the blackmail that the patients addicts bring up, and that is, I'll die. I'll be on the street. And some of them will. And how does a family handle that? It's a very tough problem, but I think it's where our field is going to answer that question. Here's the interesting thing to me is to organize clinical care more generally in this concept. I'm not going to go into that in detail. But here's the 5-year recovery standard, and this is published in our paper about this. The sustained abstinence as a way of measuring outcomes of treatment, and then bringing these other factors in to make that more likely to happen. One of the things that we need to do is have more research on this, and I would like to encourage folks here at PSI to think about using this standard for yourselves, because you're going to set the standard for long-term outcome. And I think it's something very good. I like to say what ought to happen in a treatment program is everybody who comes in, the people who are doing the treatment say, our goal for you is 5-year recovery. And I want you to hold us accountable, and we're going to hold you accountable. And the family, so everybody knows that's what we're trying to do here. We're not trying to have a little less drug use. We're talking about 5-year recovery. And let's talk about that. And so when they come in, we don't only get the data from the patient, but family, and say, we want to keep track of how Sally is doing. And if we can't get to Sally, we want to get to you, because we want to keep track of that. And I think you're going to learn a lot from doing that. My goal, where I started with, make recovery, not relapse, the expected outcome of substance use treatment. Healthcare reform gives us a lot of potentials for this. And I think the inspiration comes from the PHP model. Now, I've got a bunch of other slides, but I'm going to stop here. And I want to sort of come back to a couple of thoughts that I want to get you to think about with me. And that is, why did the physicians' health programs come up with this idea? How did that happen? Because it's so different from, I'm a psychiatrist. If you talk to mental health people, they never talk like this. I mean, this couldn't be more different from what the smartest mental health people would do. It's entirely different. And it's tougher. It's a standard of what you're expecting, and you're going to enforce it with consequences. There is nothing in health or mental health that's like that. So how did this happen? And why would it be doctors? And I have an idea about what it is, and that is that this movement was very unusual because it was led by doctors in recovery. Doug Talbot was one of the leaders who got this started, and it grew out of another movement, the Employee Assistance Program, which worked in workplace settings and also focused on people in recovery themselves. And I talked to Doug Talbot about it. I said, how did you ever get this idea? Where did this come from? And he said, because of his own experience. He had an idea that as long as you're talking to the using drug addict, you're not talking to the person, you're talking to the drug. You're not going to make this sale to that person. That person's in a different place. These physicians that we did that follow-up, when they came, they were all mad. None of them wanted to be there. They thought it was unfair. They were railroaded. They wanted to hire a lawyer. 100% of them think that. So if you're offering a treatment and you're going to please the person coming in, you got a problem with what you're going to do. And you know, it isn't just the addicts, it's the families. The families' feeling is, you're the experts, you fix them. I don't know how to do that. I turn him over to you, send him back fixed, or her back fixed. I'm telling you here today that no treatment, even PSI's excellent treatment, ever fixed any addict. And it never will. Recovery is something that is a process that is for your life. And it requires work from that person in recovery. Now, what does treatment do? Why do we spend the money on treatment if it doesn't fix them? What treatment does, and it's very precious and very valuable, is it defines the problem. So the person can understand what's wrong and has the tools to grasp that and see that, whether it's brain science or behavior or whatever else. The treatment tells the story of the disorder or the disease, and it teaches the person about that. It says how serious it is. Talks about what the consequences are. Talks about the fact that they're part of a community of this. It's not just them. And then it does something else. And that is, it defines for the person the path to recovery. And here's what you need to do to manage that disease. Not because you're fixed, but you're on a path. And that path is what you need to be on to achieve the goal of recovery. It's going to be a lot of work, but it's very rewarding. And one of the things that's very exciting about going to meetings and very exciting about the kind of treatment that is done here is the new people can see the people who are further down the road. And that gives them a tremendous sense of hope. Look at those people who are further down. What do they have? How did they get there? And one of the things I would say, that this word recovery, now, I don't know how many of you are involved in medication-assisted treatment, methadone and buprenorphine and these other, but that is the dominant way this country is approaching the opiate problem, is through medication-assisted treatment. And in that world, there is none of the word recovery. And the concept isn't to not use. So those people do not have sobriety dates. Whereas everybody in recovery has a sobriety date. It's like their name. Wear it like a badge. I think that's important. That's a different way of thinking about what the problem is and what you're doing about it. And it's very, very fundamental. Now, many of us in the recovery community, I think about myself like that, and you all like that, and the PSI people like that, is what do we think about medication-assisted treatment? What do we think about methadone? What do we think about buprenorphine? And many people have the view that that's just another drug. So you can't be in recovery because you're taking a drug, because those are agonists. Okay? I don't have that view. I told you how I got started in Washington, D.C. in the Department of Corrections. I started one of the biggest methadone programs in the country. That's what NTA was. Methadone was invented by Vincent Dole and Marie Neiswinder. They became my friends. When I went to New York, I stayed in their apartment. They came to dinner at my home. I steeped in medication-assisted treatment. So, and Vincent Dole was a non-alcoholic trustee of AA, which people don't realize. It's pretty striking about that. And I did a study of a methadone program in Washington to show that 65% of the people in that program go to AA and NA meetings. And the people running the program didn't even know that. And they felt the AA was helping them and the NA was helping them, which is also very interesting to think about that. So here's what I say to you about this issue, this controversial issue. If a person, an opiate addict, heroin, OxyContin addict, is taking methadone and buprenorphine as it's prescribed, not shooting it, taking the dose that it's prescribed, not selling it somewhere else, and is not using alcohol and other drugs, I'm happy to call that person in recovery. To me, it's a medicine. I don't have a problem with that. Medicine is okay. But if that person is drinking, if that person is using other drugs, they're not in recovery on being on methadone or buprenorphine. So I'm making a very sharp distinction here. And if we're going to reach out to the people in MAT, we have to take that position. Otherwise, we're standing in front of a train that's coming at us. And that's not smart. But by taking this position, I think we can help them focus on what they want to achieve. And if you use the 5-year standard, I think they're going to do okay, because they'll have a fair number of people who do, over a 5-year, stay with the program and who don't use other drugs. I think us on the drug-free side are the ones who are probably going to have the hardest time with that standard, not the easiest time with it. But unless we have that modification or that accept that view, I don't think the game doesn't go on. And then it's just we're fighting back and forth in a way that nobody's wins. In fact, there's a long history in drug treatment of one treatment fighting another one, and the bottom line of that is to take away this public support for either of them. That's not a winning strategy. So what I'm here to say today is that the result of my nearly 50 years in this field of caring about addicted people, of watching in my, I have had patients of my own all through this time. I still have patients every week in my practice now. I learn from the patients. I see they're my teachers. I care about them. I think that where we are, where I am, is that this model that is pioneered for more than 40 years in the PHP movement sets the standard. And from that, everybody can learn about what they need to do to make treatment better. So that's it. Any comments? Yes?
Do you have the same view on benzodiazepines? So if someone has co-occurring opioid and anxiety, what's your view on that? Because I know there's controversy around.
Yes, there is. There's nothing. The benzodiazepines are unique medicines that they have been controversial from the beginning, and it's not going away anytime soon. In 3 weeks, I'm on a program called AMERSA, the American Society of Medical Education in Addiction, and I'm debating that exact point. Now,
Where is that at?
in Washington, D.C. It's a group of medical educators. But what's interesting is that I had a crisis in my own professional life. Dan was saying I was the head of NIDA, and I was the head of NIDA for 5 years. What he didn't tell you, I was fired as head of NIDA. And that was a crisis in my life. We got a new president, Jimmy Carter. He had a new secretary of HEW, Joe Califano. And Califano wanted new heads of the institutes. If you were there the day before he came, you were gone. You didn't care what party you were, how good your job was, you were gone. First he got mental health, then he got alcohol, and then me. And this was devastating to me at the time. And I became, sort of lost my focus. And I thought maybe the drug thing was a fluke, and I wanted to do something really different. And I had a patient in my practice who had agoraphobia. So I invested myself in the treatment of anxiety disorders. I'll get to your question, but I want to give the background. Because I'm really, Dan was talking about my books. I've also written books in anxiety. The Anxiety Cure, for example, is sold more than any of my drug books has. So I started the Anxiety Disorders Association of America, the national organization. I started as the first president. And so I have deep roots in that. And the benzodiazepines are unique because they're so big in both anxiety and addiction. And in addiction, the benzodiazepines are booze in a pill. It's that simple. But what you don't realize is that the typical anxious patient who's not an addict or an alcoholic will take these low doses of benzodiazepine, have great results, and never raise the dose. You don't have to work on it. It's not a problem. But when the world that I live in my drug field, they're a big problem because people these big doses, they don't get a good result, and it's part of a syndrome of use of other drugs. So my position for the debate is don't do it. So my simple answer is, among drug addicts and alcoholics, don't use the benzodiazepines. And then I got a little asterisk, except sometimes. That ruins the debate. And what you want to look for is how the person is using it. Are they using it like an anxious patient, or are they using it like an alcoholic? Are they not drinking? Are they not using drugs? Or are they using those things? So you got to sort of think about that one at a time. But if you do it at all, you've got to be mindful that you're going to have failures. Even the people who look like they're perfect will occasionally blow up. And so I tell the patients, I'm concerned about this. We're going to watch together, and we'll see how it works out. But I'm concerned about it. And I tell them why. about it. So that's where it is. But the one thing I want to tell you about anxiety disorders is, because this is another life of mine in anxiety, most people do not understand how painful anxiety disorders are. And so they analogize their own anxiety to the patient's anxiety. This is a disaster. Do not do that unless you have an anxiety disorder. And what I say about the anxiety disorders, unlike cancer or heart disease, the anxiety disorders never kill you. So it's not going to be fatal, but it's worse. Because what anxiety disorders do is rob you of the enjoyment of your life. The cancer will just kill you. But the anxiety disorders, I had one patient come in, then I thought he was an old guy, now he was 70, I think he's a young guy, comes into my office and he said about his anxiety disorders, he said, I've had a terrible life. The only thing is most of it never happened. That's right. That's what the anxiety disorders are all about. So please, when you're dealing with somebody with anxiety disorders, take the suffering seriously. On the other hand, anxiety disorders are not a benzodiazepine deficiency disease. And there are ways of handling it, including no medication. And how do you do that? And this is how hard it is to do our drug treatment. That's how hard it is to get to this place with anxiety. And that is acceptance of the feelings. Your brain is giving you a false signal of danger, a false alarm. And you need to disregard the alarm. That's easier said than done. But it can be done. And the reason it works is this. The anxiety problem is not the panic, or not even the anxiety. It's the fear of the panic and the anxiety. It's called the second fear. That's what keeps the person crippled. The panic attacks are occasional, but the fear of the panic attack is permanent and continuous. And that's what it is. And so the one-word acceptance for all anxiety disorders, the one-word antidote for all anxiety disorders is acceptance. Let it happen. Don't be afraid of it. You can survive the panic. You can do anything. You give a speech with panic. You drive a car with panic. It's not much fun, but you can do it. And once you get yourself aware that you can do that, it changes the game. So, the drug treatment is pretty complicated. You're not going to teach somebody how to do drug treatment in 5 minutes. I'm not teaching you how to do anxiety. It's that complicated and that challenging, but that's the basic argument. A basic point of view of what you're trying to get to. Other questions? Yes?
I'm not sure I'm very clear on this question, but I liked what you explained about medication-assisted treatment, and I work at an abstinence-based treatment center, so we've been having these conversations.
Oh, yes,
a lot
yes.
around this, especially with the particular clinicians that model attracts, of like, how could we bring them in, and do they need to be separated?
Yeah.
To have an MAT group and a sober
Oh, yeah.
group, and I'm just wondering if you have any thoughts
I
on
do.
how integration goes with that.
As passionate as I was about anxiety, I'm more passionate about this. The fount of abstinence-oriented treatment is Hazleton. You know that program in Center City, Minnesota? That's where it started. All the things that we're doing, the PHP treatment, the treatment part of it, is from that model. Okay. Hazleton started 3 years ago in an abstinence orientation to use buprenorphine and naltrexone. And everybody, this is heresy. This was terrible. Everybody said it wouldn't work. And it's worked wonderfully. I've been there to talk to the patients. They're mixed together all the time. All the time. They get along just fine. And they talk about it, whether they're taking buprenorphine or naltrexone, Vivitrol, or whether they're not doing anything. They're all in the same places all the time, talking with each other about it. And they talk about some of the pluses and the minuses and all of this. You don't have to have that battle. It's a sort of a religious battle. But what's different about Hazleton's use of buprenorphine and what's happening in buprenorphine in your community is it's in the context of an abstinence-oriented program. Most of the buprenorphine that's going out isn't in an abstinence-oriented program. It's just write the prescription. There's no program. That's not drug treatment. So I think it's really, if you say it's buprenorphine or not, you're missing the fact that buprenorphine can be part of an abstinence-oriented treatment or not. This one I don't think is going to do much for people. This one I think can be very helpful. So I encourage an openness to that with the standard of no use of alcohol and other drugs. Just because you're taking buprenorphine doesn't mean you're going to drink or use other things, because that's not, we're an abstinence-oriented program. But the medication can be accepted in an abstinence-oriented program. That's a step that we on the abstinence side, I think, need to take. So that's where I am with that. Some of your people will be members of ASAM, physicians, American Society of Addiction Medicine. They have a magazine. And I wrote an article about exactly this point about a month ago. You can get a copy of it. And the discussant of my article was Tom McClellan, the very guy I'm talking about, who is the leading buprenorphine guy in the country. So it's really, I encourage you to take a look at that ASAM magazine, which exactly deals with this issue. Other questions? Yes?
Putting aside the idea that health and wellness is different than sobriety, the HOPE study I think is interesting, right? In that, let's say you're sitting on a hospital board.
Yeah.
And I'm worried about the physician, they're dependent, let's have the monitoring, let's have
Yeah.
the leverage of their career. Let's not pay for treatment.
Right.
How would you respond to that?
So we asked the doctors that in the 5 years after. What would you think if you just had monitoring? Could you have done that? And would that have been a good thing? They weren't completely on the one side, but they basically felt it wouldn't have worked for them.
The HOPE people are different.
Yeah, well, no, I don't think the HOPE people are getting the full treatment, and I can justify that on the basis of the costs. But I think that they've maximized, well, I should say, minimized the cost, and PHP's maximized the benefit, and I think both make sense. I think it's interesting, but I think just doing the monitoring, the problem with the physicians doing the monitoring is that they don't get the other things that are in there. They don't get the recovery orientation. They just get stopping using. And I think that would be a loss.
I think for the physicians, but I'm wondering if the hospitals will care.
Well, I think there's a whole question about what gets paid for in any event. And I think that that's really a horrible problem that we have. Marty Dude, I mentioned. Does anybody know who Marty Dude was? You do? Few of you do. Okay. Well, I think you probably think he was a saint too. At least that's the way I think about it. But he told a story as an addiction medicine physician that I thought was really interesting. He was fully invested in residential treatment and would fight with the managed care people about getting more days, and they were trying to cut them down to 2 weeks and 1 week and all that stuff. He'd do battle over and over again. And then he formed a group of addiction medicine doctors, and they had a carve out from a managed care program to just do the addiction care. And they had this pot of money. Do all the residential care you like, but this is all the money you get, and you have to treat all these patients. Guess what he did? He did IOP. All the ideology was gone. Now we're just practicing with that money. That's what we do. So I think that's, and I don't dismiss that. The costs are significant and meaningful. I think those are really valid questions. And I don't know. One of the things that I think about is, I think about my family. Where would I want to send somebody who has a substance abuse problem? What would I want to see happen there? I said this to a group of researchers in addiction, and I was talking about saying, let's say I've got a family member, which I don't, but if I did, who had an opiate problem and was using heroin. Where in my list of options would giving him clean needles be? You know where it is. I couldn't believe it. The majority of those researchers, it's exactly what they wanted to do. Exactly what they wanted to do. And they thought, I said, you'd be responsible for your son or father or whatever dying. Because that's the alternative, or getting HIV. I couldn't believe it. It was such a different mindset to me. I would want to get them to stop using opiates. What do I have to do that? No. And the same thing is true about the medication. You know, would I want to put them on buprenorphine? Would I want to put them on methadone? Naltrexone would be easier, but you know, it would be hard for me to do that. But that's where I'm coming from, and I have to say there is another point of view about all this stuff. Other questions or comments? Yes?
Age group, particularly the physicians are well established in their career.
Yeah.
And they're a little
Right.
older, especially
Yeah.
with opiates these days.
Yeah.
You know, you're looking at teens and young adults who have issues about launching to begin with, let alone maintaining boundaries.
Are you working with these people? Okay. Now, one of the things about drug treatment is the drugs are all about kids, have always been that. It's always been about kids. And who's in treatment? Never mind the PHP. It's people in their 30s, 40s. How many treatment programs are there for teenagers? There's not very many. And anybody who's working with the teenagers, they're used to having a lot of challenges and a lot more frustrations and relapses. That's right. I think it's very difficult. And there you see, there's an example where medication might make a difference to be able to hold on to the patients. I can understand that.
Right, so 20-year-olds are the worst.
The worst. Yeah,
Mentally, they're 13.
yeah, that's right. Well, they say the thing they say in AA is that your maturity stopped when you started using. So if you started at 13, that's when you stopped maturing, kind of a thing. But you know, to me, about the kids has to do with the responsibility of those parents. And to have a kid who's using, and you're tolerating that, is a real trouble for me. And I come down, and I can say this from a distance, on, listen, this is the way it's going to be. You're out of here. I'm done. Many years ago, I was asked to be on the Today Show about the first generation of American parents who had themselves smoked marijuana. And so I went up to New York to this thing, and I thought I was going to be talking about parents who were very permissive. No, the parents I was talking about said to this 13-year-old, who was the older of two sons, that they had had a terrible time with marijuana, and they weren't going to put up with it because he was going to get the younger brother to use, and he was out of the house. And they had this film for me to look at. I had no idea that's what I was going there to discuss about that. But I honestly think that's the kind of thing that they need to do. And it really is the thing that turns a lot of people around when there's a line drawn in the sand. On the other hand, I had an experience with the editorial page editor of one of the leading newspapers in the country, who I saw and advised and was very involved with his family. And he had a daughter who had a terrible opiate problem. He took the tough line view. 20 years later, she's just a lost soul. It's really horrible. So I think anybody who thinks that that's an easy decision to make, it isn't easy to make. And I think part of it has to do with how many times do you have to fail at the soft approach before you take the hard approach. And you know, there's a difference of experience and how you feel about it. I know families who can't never pull a trigger. And that's okay too, I can understand that. The problem with it is it's enabling the addiction to go on. And you know, and they know that because they've seen it happen over time. I tell you, a lot of people I have worked with who've turned their lives around have turned around because the family said no more. I was giving a talk in Long Island some years ago, and I had the cab driver. I always talk to the cab drivers, I guess everybody does. And he wanted to know what I was doing. I was going to this talk. Well, he knew about drugs. He was a heroin addict. So we had a chance to talk about that as we went out there. And I said, it doesn't look like you're using heroin now. He says, no, he's not. I said, what happened? And he described the experience of his family being fed up with him, throwing him out, and him having a terrible time. It was a rainy, cold day, and he knew the family was having Sunday dinner at 3. So he showed up on the front porch and wanted to be brought in. His mother came to the door and said, "Are you clean now?" And he said, "No, but I'm going to do it." And she slammed the door on him. And he said, that was the moment it ended. But it doesn't always work out that way. Other questions? I think we're probably out of time, are we? I'm here to stay till 3, but I don't know how long you guys got. You want to call it? Yeah, go ahead.
You may have just answered this question with the last comment, but it seems that these trials and these subjects for more people have a choice of career or not, or freedom or not. Has this model been used with people who don't have something like that over top of them?
Well, that's right. I mean, you think about the homeless people, for example. What have they got to lose? How do you deal with that? And I think many homeless shelters insist on being drug-free as a condition. I think that's a tough problem. I really do. I was saying to Dan, I had a physician patient who was an oncologist, and his patient's family would bring him in all the opiates when they die, and he had endless amounts of opiates to use, shooting them, and he kept going, and he was my patient, so I sent him to the finest physician's health program, treatment programs in the country. He was thrown out of all of them for noncompliance. He lost his wife, his kids, he lost his practice, he lost all the money he'd saved up for his retirement, he spent on drugs. He had a car, he lost the car, he had a bike, the bike got stolen. He was homeless in Washington. And I kept track of him because I knew his family, his parents, and his mother one time said, "He's gotten better." I said, "Oh, really? What happened?" He turned himself into the VA homeless program, which is amazing to me, and got into the PHP program for his state. He's now practicing oncology again. Goes to a lot of meetings, but it took him a long time. He had to suffer really a lot till he got to that. But I think everybody, the other thing that I think about, people that live in a different part of the community, go into the part of the community which is lower income, minority groups, and you will find AA and NA meetings there. And talk to those people about that and what they think about it, what those stories are. Because I think recovery doesn't have to do with your income or your intelligence or any of that stuff. And I think that those meetings are perfectly good for those folks. And they got lots of bottoms that they can use in a very positive way. And they're just as happy about their recovery as the physicians are about theirs. Okay, I'll stop there. Thank you.